Hello, my name is Kate. I'm a PT assistant. I work currently at the Jaffrey office. I've been a PT assistant since 2012 and became a certified lymphedema therapist in 2017. And I'm here with Kim and Jamie, and we're here to present information on lymphedema, how it can affect your daily life, as well as cover treatment options and strategies. So the lymphatic system sits parallel with the circulatory system throughout the entire body, from the brain through the extremities and then deep within the abdominal region surrounding all of the organs. Its job is to filter bacteria, makes white blood cells, increases immunity, and assists in digestion, maintains a fluid balance within the body. The vessels are superficial, meaning close to the surface of the skin, as well as deep. They run along the capillaries with the arteries and the veins. These are little tubes that transport the fluid throughout the body. They have one-way valves similar to the venous system that don't allow fluid to go backwards. It only goes in one direction. Similar again to the venous system. They do not have musculature like the arteries do, which means they rely on muscle pump action and movement or external pressure to move the fluid along the system into the next valve and eventually up into the nodes. The nodes sit within our joints, so in our knees, our hips, our elbows, along our neck, in our armpits, as well as deep within the abdominal cavity surrounding the organs and within the brain. I tend to think of these things like turkey basters, where they have to be squeezed for the fluid to be moved. They get squished, pushes the fluid out, and then it fills back up with the remaining fluid that's below them. So it pushes it up through the chain, through the vessels, and on to the next node. So nutrient and oxygen-rich blood is pumped from the heart through the arteries to the capillaries, where it's pushed out into the interstitial fluid, which is the space outside of the organs and the cells. The organs and cells absorb the nutrients that they need. And then the venous system picks up about 70% of this fluid to return back to the heart and lungs. The other 30% is picked up by the lymphatic system, and it's filtered through the lymph nodes. This fluid is cleaned through the lymph nodes, brought into the cisterna chyli, which is deep in the abdomen, up the thoracic duct, which kind of follows the spine a bit. And then it's dumped back into the circulatory system through the subclavian veins, which then is excreted through the kidneys. So lymphedema, by definition, is an abnormal accumulation of fluid outside of the cells caused by a mechanical insufficiency with a protein buildup. The protein is important with the lymphedema. Basically what this means is there's an insufficiency within the parts of the lymphatic system somewhere along the chain. Therefore the fluid just kind of sits outside the cells, waiting to be picked up, accumulating protein. It can be caused by trauma, injuries, or surgeries, lymph vessel destruction, node removal, radiation, chemo, tumors, burns, infections, compromises of the vascular system, or congenital malformation of the lymphatic vessels. Edema is an abnormal fluid buildup without the accumulation of proteins. This can be caused by chemical failure or decreased reabsorption rates in the body, such as CHF, renal diseases, arterial insufficiencies, chronic venous insufficiency, thyroid disorders, trauma to the tissues, immobility, pregnancy, or pressure from objects like tight jewelry, bandages, or compression garments. Edema can be pitting, but can resolve with correction of the condition that's causing the edema. Contrary to edema, which is a low protein swelling, lymphedema is a disease rather than a symptom, and its underlying cause, the insufficiency of the parts of the lymphatic system, cannot be reversed. Lymphedema can present in the extremities, in the head and neck, trunk, or in the genitalia. The abundance of the protein and water in the tissues may be gradual in some patients and sudden in others, but always results in a high protein edema, which we call lymphedema. Lymphedema is irreversible without treatment, so if it doesn't get treated, it's just going to get worse, where edema itself can be corrected if you fix the original issue. There is another condition called lipedema that affects the lymph vessels. It's a loose connective tissue disorder where the vessels are corkscrew shaped rather than more of a straight line, and can present itself at various life stages. The etiology is unclear, seems to be resistant to diet and exercise. The symptoms are a symmetrical, pear-shaped lower extremity edema from hips to ankles, but does not affect the feet, but it can also affect the arms. The skin is sensitive to touch and bruises easily. Treatment sessions with a certified lymphedema therapist are very similar to lymphatic conditions, including self-massage, exercise, and compression. So there's 4 stages of lymphedema, from latency to elephantitis. Latency, or stage 0, is early and is correctable. There is no noticeable swelling, but the skin feels tight, tingly. Your clothes might fit a little differently. If treated early, simple interventions such as self-massage and light compression can reverse the symptoms. Stage 1 presents as intermittent swelling, but elevation and self-massage can help reduce the swelling and provide some relief. If treated here, interventions, compression, and self-massage can stop progression and provide some relief. Stage 2 is chronic swelling that does not reduce with elevation. So it doesn't matter how long you keep your feet up in the air, it's not going to reduce the swelling. Tissues are firmer to touch with less pitting due to a fibrotic buildup in the proteins that kind of gets hard. Treatments include targeted lymphatic drainage techniques to address the fibrosis and to reduce the edema. Compression is super important at this stage to limit progression and then maintain the fluid reduction. And then stage 3, the tissues are very fibrotic and hard with thickening at the surface. There's a great potential for opening and seeping areas with poor skin integrity. Because of the potential of open areas and reduced lymph movement, there is a high risk for infection. Treatment is very beneficial to reduce the fibrotic areas, improve skin integrity, and facilitate fluid exchange with compression, self-massage, and exercise. So, when should we start looking for treatment? If you're asking yourself this question, you should probably be looking into treatment options. Notice any sensation changes, heaviness, tightness, skin sensitivities and aches, dry, flaky, scaly skin, and edema that hasn't reduced from a surgery or trauma. So contact your medical doctor for a lymphedema referral. So because the treatments of lymphedema stimulates the lymphatic system and causes a spontaneous fluid overload in the body, there are times when lymphatic treatments cannot be performed for risk of harming the patient. Patients should be cleared of cardiac and kidney disorder exacerbations, such as CHF or renal failure, for the last 8 weeks. So you just need to be medically stable for 8 weeks. If there is a new sudden onset of edema, the patient must be cleared of DVTs, CHF, and renal failure. Patients with arterial insufficiency may not obtain compression due to the risk of further reducing the circulation to the limb. And then treatments must be held with active infection or fever due to the risk of spreading the infection. Aortic aneurysms must be monitored very closely. If at any time during treatments or after your treatments have been completed and you're just wearing garments, if you experience any of the following symptoms, stop treatments immediately, take off your compression garments, and then contact your doctor. So that includes shortness of breath or heaviness of the chest, changes in urinary output, especially a reduction, increased fatigue or decreased activity tolerance, increased swelling either at the limb being treated or in other areas of the body. So sometimes when we treat a leg, the arm will swell up. Any sudden onset of pain or a sudden weight increase. Okay.
Okay. So I'm just going to talk about the evaluation and monitoring of lymphedema. So, there's a few different ways we can diagnose and we can tell that it's lymphedema. The first way is probably just going to be clinical examination by your doctor and or therapist. They'll just check the skin integrity, the texture of the skin. Is it soft, fibrotic, pitting? Is there any open wounds, which can often happen? Circumferential measurements, comparing the limbs to each other. We can do that in the clinic as well for limbs and trunk swelling. That's fairly quick, easy, and reliable. The water displacement volume measurements, it's kind of like a low-tech type of thing, but we can use it for upper extremity lymphedema, where we would fill this with water, put the hand in here, and then measure how much water comes out. And then we can check that each time in each session to see if the arm swelling has gone down. Bioelectrical impedance analysis. That's a non-invasive machine that measures body composition. So it's lean mass versus fat versus body water. It's used to detect lymphedema transport impairments and diagnose subclinical and early stages of lymphedema. So that would be stages 0 and 1. As fibrosis and tissue changes, it may be utilized as a diagnostic tool. So we do know that Beth Israel has one of those machines, and that's more of a specialized way to diagnose. Tissue tonometry, that is a device that you can use to check for fibrosis in somebody's outer skin. Pyrometry, infrared measurement of limb volume. That's an optoelectrical imaging device for measuring indirect volume, and it is used for assessment of volume, but not as a diagnostic tool for lymphedema. We use ultrasounds to rule out DVTs and just check if there's an impairment in the outflow. MRIs can also be used, so you can assess if something's fluid versus fat. ICG, that's a device, it's a green dye injection that will assess lymph flow. It is normally in a linear pattern, and this will detect if the pattern is more of a splash of stardust or more diffuse in formations. So we have a example of that. The ICGs are also used in some surgical procedures if they're going to connect a lymph vessel into some of the veins, and so that's another specialized piece of equipment. And it's pretty self-explanatory, so it's just going to show like a normal what's happening with the lymph flow on both legs. And you can kind of see it going through the lymph nodes and up the leg. In the early stages. So there's a backflow there on the right leg there. The technology is getting better, I think, and I think it helps all of us sort of understand, and helps the surgeons when they're going to be doing any type of surgery for impaired lymph system. Okay, and then the last one was lymphoscintigraphy, which that's another. That's more of a deep. It's also an injection, and where they inject either in the hand or in the feet, and there's a large protein that's marked, so it's a radioactive protein, and they can follow that up through. And that one's going to be a little bit more superficial than the ICG technology.
So my name is Jamie Hummel. I'm also a lymphedema therapist. I've been here for 10 years, and I learned about lymphedema therapy from Kim way back in the day, and she lured me in. So I'm going to talk about what a treatment session looks like and what that entails here. So lots of words on here, but ultimately what we do in treatment, it's called complete decongestive therapy. So it's getting all the fluid out of that affected limb. And there's different ways that we go about doing that. It's interesting because when I was kind of doing research for this, one of the papers was talking about this Alexander von Winnewater, who published a book in 1892 calling dielephantiasis, which is really the beginning of our understanding of lymphedema. So what I thought was pretty interesting is that was 1892 when we first started talking about it. We didn't really start studying it in this country more elaborately until 1980, so big lapse in there. In 1932, we had the Vater group there, Emil and Estrid, who really advanced the original concepts from 92 and coined the phrase manual lymph drainage in 1932. But that was over in Europe, where they tend to be a little more holistic with things and understood this a bit more. So it's taken a lot of time for it to come over here and for us to really acknowledge and start treating it. So interesting how we went from 1892 to 1932, and really not until like the 2000s when we started doing more emphasis on it here. So over the years, though, the basic components haven't really changed. The gold standard is still manual lymph drainage and CDT, that complete decongestive therapy. So that it's kind of interesting how we're still in that same place, with just the little tweaks here and there. So when you come in for treatment, first the doctor will send over a prescription saying you need therapy for this. We'll go through, ensure that you have the clearance from the appropriate medical professionals to make sure that your heart and your kidneys are ready for the movement of this fluid. We'll go through taking measurements, looking at your skin, documenting all of these things, figuring out when did it start, what's the reason for it, so it helps us understand what it is you need for treatment. And then once we have all that information, we'll develop a plan of care, looking at what components of the therapy that you require, and also what's an estimate for duration and frequency of being treated. Let's see. Oh, I did it right. Okay. So the first phase is the more intensive phase of therapy. That's when you're going to see the largest reduction of fluid from the affected body part. So generally, you're going to see a lot of compression during this time. If you're in stages 2 and beyond, 0 to 1 may or may not need compression. It might be a matter of preventing things from getting larger at that point in time. Has anybody been in compression garments, either bandages or wraps? Okay, there we go. So, so back in the beginning, we used to always use short stretch bandages. And those are like an ACE bandage, but an ACE bandage stretches up to 100% of its size. Short stretch bandages only stretch, I feel like I have a wire on me here. And I do. Short stretch bandages only stretch an additional 25%. So having that helps to prevent increased swelling and also provides pressure from the outside of the limb against the muscles on the inside, moving fluid out of that section that's impacted. So it's a harder, more rough material than you would have on an ACE bandage. And after we get done talking, we have stuff up here people can come touch and all of that and try stretching. So this is what we used to use all the time, and you'd have an underlay, and then a soft foam would go underneath that, and then we would bandage from the end of your foot or your fingers up towards your trunk, and that would help facilitate movement of the fluid out of those tissues. Now we have these lovely Velcro compression bandages, which, oh gosh, I think they've been around 10 or 15 years and they've been pretty well studied. And instead of having to bandage roll all these bandages up and apply them, now it takes a couple of minutes just to put this Velcro on. So people tend to really like that. You can there's a couple different styles. You can start at the foot. Most people don't like going all the way up to the top of the thigh. I find a lot of resistance for that. But in multiple pieces, sometimes you can use 3 pieces, 2 pieces. So, and the benefit of that is as your leg reduces throughout the course, even in the beginning especially, through the course of the day, it's easy to readjust that Velcro instead of having to take all of those bandages off and reapply to have them on there, right? It's just a matter, I tell people when you go to the bathroom, just check your bandages and readjust them so that they're snug and comfortable. So that has been a lovely invention. And because bandages and the Velcro wraps should be worn 23 hours a day in a perfect world. So they only, they only come off. This is general. And they usually should only come off for hygiene, taking your shower, doing skin care and management, and then they go back on. And that varies per the plan of care that's established when you first come in and we see how things are working. What we hope with these bandages and garments is that your leg will reduce. Eventually you'll hit a plateau, it won't reduce anymore, and then we would move into like a maintenance phase at that point in time. All right, so another component of complete decongestive therapy is manual lymph drainage. And have folks here had that done? Yeah, not the worst thing ever. So it's not a deep tissue massage. A lot of us really aren't happy with the fact that they call it's kind of considered like a manual massage or things like that, because it's very different from a regular massage. If you've had a deep tissue massage and you've had manual lymph drainage, it's a very different feeling. MLD, manual lymph drainage, is very superficial. We're just working on the outside, the top layer of your skin. And this stimulates the lymph system, and we start in the trunk area to clear the way, and then we'll work out through the affected limb to the end and then return back towards the trunk to help clear the pathway so this fluid can get back into your circulatory system and dump back into all the places it needs to go. It's really gentle. If you find a freckle on your arm, and you put your hand above it and you just stretch the skin towards your body, that's the amount of pressure that manual lymph drainage usually takes. So it's just a matter of moving that freckle. If you have denser, more edematous tissue, it takes more pressure to move that. So it varies depending on what kind of tissue changes you've had in your body at that point in time. So it's important to work with a skilled therapist when you have this done. There are people that are trained in just general lymphatic massage, which can be great. It detoxifies the body. But if you have a disruption of your lymph system, you need someone who understands how to work with that dysfunction and not cause any safety issues to you. Because if we push fluid in the wrong direction, if you have some missing hardware in your lymph system, it can kind of cause a little bit of a buildup. So we want to make sure you get the most out of this strategy. So we always work starting proximal to distal and pulling towards the trunk. It always feels a little bit like rocket science because our hand movements change in placement, but we're always stretching the skin towards the trunk because that's where we want the fluid to go. So therapists do teach patients or their caregivers or family members how to do this at home to help keep things moving, and that you can still have that same therapy and interventions at home as well. So another really, really important part of managing lymphedema is skin care and integrity. Everywhere you look, when you read all the studies, is meticulous. We want meticulous skin care. When you have edematous tissues anywhere in your body, you're at higher risk for an infection. The protein that's present in those tissues is what feeds bacteria. So this is where you hear about cellulitis and things like that, which can be really dangerous if untreated. It's 100% treatable, but if you don't treat it and leave it to fester, it can become a fatal event. It can go systemic. So that's why we're always really cautious with folks when they come in and they have red, warm, swollen areas. I have walked people to the emergency room, or we have called physicians from the treatment room saying we need to get on antibiotics and have an intervention right away to help manage this. So one of the ways to avoid that is to make sure you're drinking enough water and you're hydrating well, that you're using a really good moisturizing cream on your skin daily. They recommend low pH, non-scented creams. There are no pH levels on any of these creams, even though everyone talks about using low pH. The recommended creams by lymphatic providers are CeraVe, Eucerin, the Cetaphil, Aquaphor, are all agents that work really well. You want to avoid highly perfumed lotions and creams because that tends to actually be more drying for your skin rather than be hydrating for you. So you also want to make sure you put moisturize your skin at night or before you try and put on a maintenance garment. It's kind of cruel and unusual punishment to try and pull up a stocking over freshly moisturized skin. So I always try and recommend, like, once you take your garment off at night, that's a good time to moisturize. If you're using the wraps, you can moisturize underneath that because you don't have to worry about trying to pull up a tight garment over that. We want to make sure you're washing with non-scented antibacterial soaps, making sure you keep that skin clean, attending to small cuts right away. Make sure you clean them and bandage them so no cooties get in there, because even small, teeny tiny little microscopic cuts can allow for bacteria to get in, and we want to avoid that. So it's really important that we take good care of those. My folks, when they come in, I want to say make sure you're protecting your skin, and that means avoiding sunburns and avoiding sticking your hand in a dark hole, which sounds like a weird thing, but gardeners do this all the time. So you want to make sure you wear gloves for those things. I see a lot of people who have had bug bites, and they've been many years from their treatment, and all of a sudden they develop lymphedema because they've had this bug bite or a spider bite. There's a spider out there somewhere that is not good. So really important to protect your skin. And sunburns. Sunburns can also trigger it. Any insult to the skin. So we want to make sure we're wearing garments or sunscreen to protect ourselves. So another part of treatment, everybody's favorite, is compression garments. So once we can use bandages, we can use the Velcro wraps. The whole idea is once we plateau, we're going to get into a maintenance garment, so a compression stocking. We've got all kinds of fun things here. For arms, we have, I have a plastic bag. We have kind of like your compression sleeves for arms. Folks kind of seen this. And we have compression socks that look like a sweat sock. So they've got all kinds of styles now. People will wear compression thigh highs. There's compression pantyhose and things like that. There's body compression. There's head and neck compression too, because you can have a lymphedema in any body part. So any skin can end up with lymphedema. So various styles of that. So you'll work with your therapist to figure out what's going to work best for you and help contain those tissues the best, because there's different containment levels, and depending on the severity of your lymphedema, you might need something higher versus lower. We want to try and put people in the least restrictive thing and the least invasive type of treatment, but we want to make sure that we're not underdoing it. It's really common for people to try and get a really soft, light garment because it feels good and it's easy to put on, but you're not going to have the right containment and you're going to end up swelling. So we want to make sure all your work for reduction is not lost to that. Another thing that we will sometimes recommend is pneumatic pumps. Anyone have a pneumatic pump at home? So there's different styles of this. There's basic pumps and there's advanced pumps. We want to see, the way insurance works is we start with a basic pump and see if that's effective for you. If you fail the basic pump, you can be eligible for an advanced pneumatic pump. We have one of them here. And people use this daily. Am I throwing more things? Yep. And it helps to simulate what we do with manual lymph drainage. Thank you, Kate. So it goes over the affected limb, and then you hit start, and it will inflate and deflate and put pressure on that lymphatic limb to help move the fluid out of there. It also helps to soften more fibrotic tissues. So they can be a really handy thing to supplement your treatment in the clinic. Let's see, I'm talking about everything here. Oh, and there's also custom and off-the-shelf different varieties. So, and Medicare now is paying for garments, which is yay. We finally got that. Sort of, kind of. Everybody has a different experience. I'm hoping they're going to get it eventually. It's going to go better. It took a while. It actually went into effect in January 1st of 2024, and nothing really happened, I want to say, until like fall of 2024 for some folks, and it's still kind of hit or miss with what different garments and things like that. But in theory, there is coverage for all garments. Every 6 months, they can be refilled, which is really amazing. But some people can wear things off the counter, which is they will fit into a size that, you can just go and, that's not an off the counter. Something. The jobes that's off the, and my sock here and the sleeve, these are over the counter or off the shelf type of garments. And then they also will make custom things, which are your measurements are taken and then it goes to a factory and they make it specific to you too. So different thing. And they can do that for socks, sleeves, gloves, head, trunk, all kinds of things. We talked a bit about that. So that's the pneumatic pump. This picture is an advanced pneumatic pump. This is the Flexi Touch, and the difference between a basic pump and an advanced pump, a basic pump just goes over the affected limb, arm, leg. The advanced pumps also have a trunk piece, so that stimulates proximal, your trunk, to kind of clear all the fluid out of the way so that it's ready to receive from whatever limb. For this person, it's an arm. So it starts here, and then the compression is going to go down the arm and then come back proximally, and it takes about an hour. So you're usually about an hour. When I tell people get comfortable, set up your area, use the bathroom, get your drink, get your phone, put your news or your show on. So, and they're relatively quiet so that you're not trying to listen to whatever you're doing over this, like the dishwasher of old. And it also shuts itself off automatically. So if you fall asleep in it, because lots of people say, well, what if I fall asleep? You're not going to be over pumped. It will go off after an hour. You're not going to wake up with a skinny little stick body part, unfortunately. So and it's all programmed. So it's literally just a start. There's no craziness to trying to figure it out. All right. Another component, important component to therapy is exercise. So there are a variety of different types of exercise that is good. My favorite is water therapy because number one recommended is aerobics, but I am not a coordinated soul, and I don't want to have to teach anybody aerobics. It would be mean for me to do. Water therapy, I think, is nice. Granted, you need a pool, so that can be an obstacle. But you don't have to wear compression garments when you're in the pool doing therapy. The water itself is heavy enough to provide that external compression against muscle contraction to help move fluid out. And, most of us really enjoy being in the pool, so it's kind of like a nice type of exercise. It's also a little easier. We're more buoyant in the pool. It's gentler on the joints. And you can do more, generally. I usually have to say to people, start small and work your way up because you're going to get out of the pool and you'll feel good after you shake that water off of the 7 pounds that you add when you get out of the pool. But then the next morning, you're going to realize, wow, I really did do something yesterday. There's good exercise to be had in the pool. In general, because not everybody has a pool in their house, and we live in New England, so we only have, 2 months a year where we can actually use our pools, it feels like lately. Low intensity, repetitive exercises while in compression is what we recommend. And we will work with patients when they come in to develop the right program for you to address whatever limb is infected by this. So it's really like they recommend 3 times a week, kind of 8 to 10 reps per exercise for 2 sets. So it's not crazy what we're looking for folks to do. And it will help strengthen your muscles, which helps move fluid out. And it's good just overall for life, general health and quality. Exercise really benefits that. It's the gentle muscle pumping that aids in the absorption and the transport of fluid out of the limb. So that's the benefit to it outside of just good muscle strength. And it's really a healthy lifestyle. We all should exercise more. We all kind of fall off that wagon, right? And I'll do it tomorrow. So if we make it part of our routine, it helps improve the quality of our life. And we're available for questions and helping to start slow and then progress. So nobody has to run the Boston Marathon at the end of this in order to reduce their limbs.
So I'm just going to finish with a couple of some other things that I feel like happens to a lot of people after cancer surgery. So sclerosing lymphangitis is the new term, used to be called axillary web syndrome or just cording. So that's, there's hardening and adherence of the lymph vessels. So they've done some testing of those too. So generally, it'll happen. Sorry, my notes are different than what I had. So generally, after either radiation or lymph nodes removal or axillary dissection, some people will have some pretty tight bands that feel like tendons, and they can be anywhere in the body. So they can, a lot of times they'll start after, say, breast cancer surgery, start in the axillary region and can go all the way down the arm. They can go down the trunk. I've seen them deeper in the abdomen area too. So that's that can cause a lot of sharp pain and discomfort for people. So we do some manual therapy techniques for that. It's like a myofascial release. So we kind of release those cords, and it usually feels better for a while, may not last forever because those cords don't really go away. But we have found some techniques that really can help with that. So how does cancer and lymphedema connect? So kind of like I was saying, any surgical management. So lymph node dissections, lumpectomies, mastectomies, and most cancer surgeries can affect the lymph vessels, causing potential lymphedema and cording. And I found that even if one lymph node has been affected, both can be a problem for people. So radiation, we know that it targets lymph nodes, it targets lymph vessels. And sometimes over, maybe not right away, but it can take months or years even, and people will have a lymph issue down the road. So I think I've seen somebody 20 years later and not have a problem, and then they end up with a problem. Chemotherapy and medication side effects, they don't have a direct relation to lymphedema, but they have other side effects like neuropathy, fatigue, muscle, and joint pain that impact quality of life. So there is a few surgical interventions that are out there that are being done in some hospitals. So lympha is done right during breast cancer surgery. It's a microsurgery, so you need somebody who specializes in this, and they actually tie in the lymph vessel right to a vein. So they can do that to prevent lymphedema from occurring. Lymphovenous anastomosis, basically that's the same thing. That's a bypass, but that's done once somebody develops a mild lymphedema. So that might be done months down the road. Vascularized lymph vessel transplant, that's connecting a lymph vessel to another viable lymph vessel. And then you have vascularized lymph node transplants. And so you're finding a donor site and transmitting it to, you find a donor site in your body, and you and you put it to the edematous region. So sometimes they combine the approaches, and then liposuction can be done. That's going to be more for lymphedema people suffering with lymphedema. There is some new things out there. So I had done a lymphatic symposium 2020 in this last February. It was people from all over, researchers from all over the world, trying to come up with new ways and new techniques, so maybe we don't have to do the compression and the pumps and all of that down the road. So that's nice to know that these things are happening. So there's some gene therapies, there's some drug therapies. They definitely tie into, say, cardiac issues, and they found some, so like I think apelin, for instance, has helped with cardiac issues, and they open up those lymph vessels. So if the lymph vessels are not allowing the fluid to leave and causing like a congestive heart failure, they're finding that the link to the lymph system is making a big difference, and it can maybe help with all kinds of diseases. They mentioned Alzheimer's, migraines, and bone and kidney diseases. So that's the future. It's nice to know that things are happening, and that sparks some hope that maybe, because I feel like the lymph system has not gotten the attention that a lot of other diseases have gotten, and hopefully this will be a change for the future. So, and that is it. So we're welcome to any questions if anybody has any specific questions at all. Yes, Chris?
Do people ever get rid of lymphedema?
That's a good question. It's usually considered chronic for most people. You can definitely control it and maintain it, but it has a tendency to come back if you're not like managing it well. So
you just try to keep it at a tolerable level?
This point, yep.
Yeah, the garments usually become the new medication for,
Yeah.
It's just like putting on your shoes and socks. You do that every day. You're gonna wear your garments every day. You don't stop your heart medication. You're gonna keep wearing your garments.
With fibrosis being a possibility for both lymphedema and lipedema, do you have treatments when you come here to just be treated for the fibrosis after entering the maintenance stage?
For so lipedema and lymphedema are treated pretty much the same. Yeah, right. So, if you're coming here for treatment, we do manual lymph drainage, and we do a lot of the same other. Yeah, we can do that.
I'm just talking about
Oh,
just
fibrosis?
just the nodules, just the fibrosis. We're done with getting rid of the fluids. Could I go to my PCP and say, sign me up for whatever you folks are offering, if you're offering,
Right.
or maybe you're not offering?
With insurance, you usually have to show progress and progression.
Yeah.
With the fibrosis specifically?
With any
Sure.
any PT, OT treatment that we do, we have to show, prove to insurance that we're doing something. And they don't really like the word maintaining.
I see what you're
Yeah.
saying.
Right.
Yeah.
There are private, massage therapists that are trained
With fibrosis?
with, so there are massage therapists that are certified lymphedema therapists. There's massage therapists that are just lymphatic drainage therapists, which is not the same thing. They're learning basic techniques in school, but they don't have the certification and the advanced training that we have. So if we were going to refer out to someone to do private, basically, where, not billing to insurance, we would want to find someone that has that more advanced certification. So we know that they know what they're working with, rather than, just like a pregnancy, lymphatic drainage type thing. These conditions are more advanced than that.
So you couldn't just come here and say, I've got fibrosis all over my legs, can you fix it?
Well, we could take a look at what you're doing for home too. So like maybe changing all this stuff. Yeah, because not just manual lymph drainage, but like different compression garments and different pump. They all work a little differently for people. So we could do the whole thing for sure and figure out if there's something that you're missing in your program right now, I guess. So.
Some tissue is just resistant. And there's actually a really interesting study going on right now where they are using medication and it's reducing fibro. Did you see it? Have you watched it? No, it's not. It's Stanley Roxon. Did you watch the YouTube video on it? And so they're in stage 2 of the study, so we're a few years out, but they're seeing reversal.
I know.
Yeah. And so hopefully as they get to like the 3rd stage, they'll include more people, and they're not differentiating between lymphedema or lymphedema to get to as they evolve this study. So that's a really exciting thing. So, and it's really targeting the inflammation. So
One of, the symposium, they did talk about they described it as the lymph goes through, it's almost like a button. In a normal lymph system, it's a button, and in people with impaired lymph system, they're more like zippers. So the fluid really has a tough time finding its way out, and the medications can change that back, can actually reverse that, so that it looks more of a natural lymph vessel flow. So, but the problem is, it's like a lot of doctors, it's not well. Insurances may not cover it. It's not fully known yet what is going to work for some people, and so you really have to, find a doctor that specializes in lymphedema. Beth Israel does have a full lymphatic program and surgeons and things like that down there. So I know it's far, but.
It sounds as if attention to and management of lymphedema has changed a great deal since the lymphedema on my right side was diagnosed in 1987.
wow, yeah.
And I'd like to know if I would be able to get a referral to try, and I also have had it more recently on the left, to you guys and have it be covered by insurance, because it sounds like there can be things
Yes,
to help me
I
that
mean,
haven't
going through all
happened
those
yet.
looking at those different treatment strategies, and you're right, there's new garments, there's new wraps, there's new studies to support things, so absolutely. So it's just a matter, you don't have to talk to an oncologist for this. You could go to your PCP and say,
And
I
they
have
could
this-
refer me to.
yeah, they can
You
refer
guys.
over here, yes.
Yeah. Okay.
Absolutely, yeah,
Thank you.
yes. You see a hand?
And the
Cynthia.
relationship between fibrosis and like she mentioned, fibrosis, I mean, is that a completely separate thing, or is it fibrosis is caused by the lymphedema, or?
So lymphedema so those proteins are basically causing that fibrosis. So the
So
thickening and the
lymphedema
pitting.
causes the fibrosis, not backwards, not fibrosis.
Right. And as time goes on, it usually becomes a little bit harder to deal with if it becomes a little more thickened and
We do treat
pitting.
a lot of fibrosis, and generally what happens when there's a lot of fibrosis, you'll see swelling. You'll see the edema develop because the lymph isn't able to flow out through around the fibrosis, and you'll have skin changes with that. So we want to manage that. It's a matter of everybody's a little different. It's a matter of finding the right garment to help soften the tissue. Is it just bandaging? Do you need, there's the tribute garments, which is a foam that kind of comes in here with special channels, and that can help with softening. Some of the fibrosis pumps can be really good doing that too. So sometimes you get people who have chronic fibrosis and they've been in treatment for a while, and it just doesn't ever resolve. And so we're hoping to soften it and maintain that softening. So you
Is
have
that on that outside or
it's
inside?
kind of like in the superficial layer of skin, and if it's left untreated, you will see skin changes. Your skin will thicken, it can have like some of those growths kind of on it, you can have like scaly areas. You can see your skin can start weeping, which means the fluid's just looking for an out and it will come out through the skin, which is all part of skin integrity and maintaining that. So it's kind of like this cascading of symptoms if it's not managed for problems. So we want to make sure we're managing that. But there are times when it's a scar tissue, can you kind of turn to a scar tissue and it just doesn't resolve well. So we're always kind of like fighting this war to see what we can do to help soften it somewhat, right?
Yes.
This is kind of a basic question, but what is the difference between lymphedema and lymphedema?
I don't know. I have lymphedema.
Yeah.
So lymphedema is symmetrical and isn't related to cancer or some dysfunction that happened when I was born. It's hormonal based.
Yeah, hormonal
Or hormonal surge, puberty, pregnancy, menopause brings it on.
and genetic too. They say, you know, there can be a genetic
They don't know.
component. They're really, there's a couple different theories on it, but
So it's symmetrical and is therefore controlled symmetrically too, so I don't wear one leg, I have
Yeah, both.
both.
Yeah.
Yeah, it's
And-
usually in both, yeah. And it's usually your feet are not necessarily part of it, like feet won't swell, but your legs and hips will. And these folks, you know, they'll tell you, I diet and diet and diet, and they get super skinny up top from here up, and then have large hips on the bottom. Lymphedema can turn into lymphedema. So we treat it the same way, but that extra fluid through the legs, or it can be in there, oh, thank you, can put pressure on your lymph vessels, and then it turns into like your traditional lymphedema as well. So you'll see people come in and then all of a sudden their feet start to swell because it's just kind of extended and disrupted the vessels. Usually when I see people like that, I'll say, so anyone else in the family who'd you get your legs from? And they'll say, oh, yeah, my Aunt Judy. I got mom's legs or things like that. So there could be a congenital part to it as well. It's more tender.
Yeah.
What I see
Bruising,
different outside of the
pimple.
symmetrical, and usually it doesn't start with your feet, the skin is just much more sensitive and you bruise really easily. So those are big hallmarks too. Any more questions, thoughts? Just thrilled to be here.